Welcome back to Open Med School. Today we are going to discuss Cauda Equina and Conus Medullaris syndromes. This will be in two parts. First part we will discuss clinical features, etiology and management of Cauda Equina syndrome. And the second part I will be discussing the anatomical aspects and how to correlate with the clinical findings and the difference between Cauda Equina and Conus Medullaris syndromes. So let us start with a case. This is a story of a 45-year-old lady who came with backache, difficulty in walking and urgency in micturition. The pain she described it as starting from the lower back, going down bilaterally. That is the sciatic pain. She had a bilateral leg pain. And on examination, it was found that she had wasting of one leg. The left leg was wasted. She had difficulty in dorsiflexing the ankle. And the reflex examination showed there is absence of ankle jerk and absence of the knee jerk. And sensory examination showed there is perianal sensory loss. So in short, she had bilateral sciatica, difficulty in walking with motor weakness involving the left ankle, that is by asymmetrical weakness, and had AREFLEXIC involving both legs. So let us see the definition of Cauda Equina. This is the British Spinal Society classification. A patient presenting with acute back pain and or leg pain with a suggestion of a disturbance of their bladder or bowel and or sensory disturbance should be suspected having Cauda Equina syndrome. So this is the definition. So that is bilateral back pain with radiation to the legs with the suggestion of neurological involvement of bowel or bladder. Unusual to have bowel disturbance without bladder disturbance. And there is a sensory loss in the saddle area, and this should be suspected as Cauda Equina syndrome. So let us see what is meant by Cauda Equina. As we know, the spinal cord ends at the level of the lower border of L1 in majority of the people. The nerve roots are traveling down like this, and it has got an imitation to the tail of the horse. And so this part is called the Cauda Equina. So the Cauda Equina consists of nerve roots from L2 downwards. That is, it is from the L2 downwards. The nerve roots emerging are called the Cauda Equina. So this is, you remember, L2 downwards. And remember, this is the part of the peripheral nervous system. There is no involvement of the spinal cord because spinal cord ends at the lower border of the L1. Three terms you should remember. One is the Cauda Equina, which we have said the nerve roots below L2. Then the term conus. Conus is the lower part of the spinal cord, which include S2 downwards, that is S2, S3, S4, S5 and Co61. So this is part of the central nervous system, and that is the lower part of the spinal cord, and it lies against the L1 vertebrae. Epiconus is the segments, 5 segments above the conus, that is L4 to S1 forms the epiconus. Even though we divide into conus, Cauda Equina and epiconus, there is a lot of overlap between the physical findings and clinical symptomatology. That should be remembered. What is Cauda Equina syndrome? We will once more review. The compression of the nerves that give motor and sensory innervation to legs, bladder, anus and perineum constitutes the Cauda Equina syndrome. That is, already we have mentioned the Cauda Equina includes the L2 downwards, and our roots are passing down because in developmentally the spinal cord lags behind the growth of vertebrae, And so what happens, the spinal cord ends at the L1 level and the nerve roots has to travel down to pass out through the intervertebral foramen. So compression of these nerve roots, which are both motor and sensory. So the findings can be motor, sensory, and there can be disturbance of bowel and bladder. And that is what is called the Cauda Equina Syndrome. So we can divide it into various groups. This is one which is suggested, may be useful. One is the Cauda Equina Syndrome, which is suspected. Second is an incomplete Cauda Equina Syndrome. That is, patients who presents with urinary difficulties with a neurogenic origin. So previously we studied in Cauda Equina suspected when there is a bilateral leg pain, there is weakness, there is a neurogenic bladder involvement, or saddle anesthesia. So any of these you think that there is maybe a Cauda Equina Syndrome. An incomplete Cauda Equina Syndrome means patient has got difficulties with bladder dysfunction or a bladder function which is suspected of a neurogenic origin. Then comes the Cauda Equina Syndrome with the retention, CES-R. Patients who present with painless urinary retention and overflow incontinence. And then comes the Cauda Equina Syndrome complete. So this can be Cauda Equina suspected, incomplete Cauda Equina Syndrome. This both can be taken together as a Cauda Equina Syndrome with retention and complete. So this is how you divide it into suspected, incomplete, and complete. There are 5 characteristic features of Cauda Equina Syndrome. So we'll take one by one. 97% of the patients will have neurogenic pain bilateral. That's more important. So it is not the backache, it is the radicular pain when the root is involved, and it's bilateral in 97%. Reduced perianal sensations are seen in 93%. And the characteristic feature is the bladder involvement. Altered bladder function 92. Loss of anal tone is seen in less number of patients. It is less than 72%. Loss of sexual function, because often there is the difficulty in exploring this and the exact percentage is not known. A significant number of them will have loss of sexual function also. So these are the 5 characteristic features. I will repeat once more: neurogenic pain, perianal sensory loss, bladder dysfunction, anal dysfunction, and loss of sexual function. It is said there are certain red flags. Actually, they are not red flags. Once these findings are there, the Cauda Equina is almost complete. Anyway, this is classically described as the Cauda Equina red flags. One is a severe progressive bilateral neurological deficit. So it is bilateral. Recent onset urinary retention or urinary problem of neurogenic origin. Recent onset fecal incontinence. Perianal sensory loss. Unexpected laxity of the anal sphincter. These are the red flags. Let us see what are the common causes of Cauda Equina Syndrome. 45% of Cauda Equina Syndrome is due to herniated lumbar disc. So you can see this is the vertebrae, and when there is a disc herniation, this can compress the nerve roots which is descending down. So 45% is due to herniated intervertebral disc, and remaining things, tumors are very important. So this may be primary or secondaries. Spinal epidural abscess. So there is somebody has got an intravenous drug abuser, they can develop a abscess. Epidural hematoma, especially in those patients who are on anticoagulants. Discitis. Trauma is again a very important cause. So remember, tumor, trauma. Then spinal canal stenosis of any cause can also lead on to. There are rare causes like obstruction of the aorta, that is blood flow to the spinal cord is affected. Manipulation of the spine. So there are different other causes. So what are the things we look in the history and physical examination? Always ask about history of trauma and injuries. Use of anticoagulation. This is to keep in mind. This hematoma formation, instrumentation, intravenous drug use, history of malignancy is very important. Spinal manipulation, fever and chills. This will indicate the possibility of an infection, epidural abscess. Physical examination, you should look specifically for lower motor neuron signs in the legs. I already said it is a peripheral nervous system problem. So look for LMN signs. Look at the saddle area for saddle anesthesia. Do a rectal examination and look for the tone of the rectum or anal tone and bulbocavernous reflex. We may elicit that and it will be absent in Cauda Equina Syndrome and palpate for a bladder, whether the bladder is distended. The muscle should be tested keeping in mind the values. The hip flexors are L2, knee extension is, that is quadriceps is L3, angle dorsiflexor L4, big toe extension, remember it is a L5, and angle plantar flexion is S1. So these are the roots you should remember. And check the reflexes. In Cauda Equina Syndrome, usually the S1 root can be affected and the angle jerk is absent. And check the knee jerk. It is predominantly the L4 root, and so these two reflexes you should carefully look for. And check the sensations, keeping in mind the sensory distribution of the lower limb. And as mentioned, this is an asymmetrical areflexic paralysis. That is the most important thing. The Cauda Equina is an asymmetric areflexic paralysis. The reflex velocity is usually the angle jerk and the knee jerk, and there will be wasting and weakness which is asymmetrical. Remember the term asymmetric areflexic paralysis. And the saddle anesthesia is classical, so this anesthesia may be extending down depending upon which are the nerve roots affected. And whenever it is suspected an emergency, imaging should be done within 24 to 48 hours and intervention has to be done because this is a medical emergency. And the MRI may show abnormalities. If a structural cause is found, you should go for intervention, that is surgical intervention. Let us see what are the complications. This can produce pressure ulcers, recurrent urinary infection, osteoporosis, urethral stricture, chronic neuropathic pain, bladder calculi, contractures of muscles, and depression. So these are the complications. You have to avoid these. So we have discussed the clinical features, defined what is Cauda Equina Syndrome. The major causes we have discussed. The most important cause is lumbar disc clamps, and the management, urgent management, neuroimaging, and other intervention. Hope this was beneficial to you. If you like this, please subscribe to the channel. Okay, bye.